We'll next be discussing urinary elimination. So when we're looking at urinary elimination, when we're talking about being able to go to the bathroom, being able to urinate or to void or to pee is another name for it, we always want to use the most correct terminology that we can that will make sense to the person. So our urinary system comprises of our kidneys, which are kind of a kidney bean shaped. They're usually about 4.5 inches by about 2.5 inches. Then we have the ureters, which are usually about 8 to 10 inches long, and they connect from the kidneys down to the bladder. And then we have our bladder, and then we have the urethra. And then the very opening of the urethra is called the meatus. And so the urinary system is actually a sterile system, other than the very opening of the meatus. The rest of it is considered a sterile system. And it's going to excrete liquid waste and help manage the chemistry balance of our blood. It helps manage fluid and electrolyte balances for us as well. So our kidneys remove the end products of metabolism. So you have millions of nephrons, which is your basic structural unit. And what it does is all of the blood filters through that, and those nephrons actually remove urea and creatinine and uric acids. And so that forms urine. It just basically dumps the urine or the uric acid down the ureters down to the bladder. You actually produce a little bit of urine every 15 seconds. So the ureters connect the kidneys to the bladders. We said they're about 8 to 10 inches long. They're just muscle. It has muscles. And what they do is they tighten and relax. They do have peristaltic wave-like contractions where the muscles tighten and relax to move that urine down to the bladder. And we said every 15 seconds that's happening. Now the bladder is a muscular organ, and it's held in place by ligaments. And its job is to store the urine. So it generally can store about 16 ounces of urine comfortably for about 2 to 5 hours. So you'll find that some people, every 2 hours they need to go to the restroom. Some can last 3 or 4 hours, some 5 hours, and some even longer. But as a general rule, 2 to 5 hours is generally what people can do comfortably. There are circular muscles called sphincters which help keep the urine from leaking. And there's nerves in the bladder that actually tell you when it's time to urinate. So you have these stretch receptors in your bladder. So as your bladder's filling up, it stretches these nerves and sends a signal to your brain to let you know you're going to need to go to the restroom. When we look at female anatomy versus male anatomy, your female anatomy, you have your kidneys, your ureters, your bladder, and then you've got the urethra. But this urethra is about 1.5 inches long. It's about 1.5, 2 inches at most. And so you'll notice here's the size of the bladder. It's a hollow organ, though it does have all this muscular tissue around it. But right next to, here's the meatus of the urethra, the opening of the urethra, and it's right next to the opening of the vagina and the opening of the rectum. Where for a male, the bladder capacity is larger. Men actually have a larger bladder. Their urethra is generally around 6 to 7 inches long, and it's going to go from the bladder, and it's going to come through the penis, and the meatus, or the opening of the urethra, is right down here. So when it comes to cleanliness issues, you can see for a female having their urethra right next to the vagina, right next to the rectum, which normally has bacteria in it to help you digest food, it's really easy to get bacteria from the rectum right up into the urethra and up into the bladder system, which is a sterile system, which can cause infections. So for a man, you've got the urethral opening here, and then you've got the scrotal sac, and the rectal opening is back here. So it's much harder to actually get bacteria from the rectum, up into the bladder. When we're looking at the term urination, it is the process of emptying the bladder. So urinating, voiding, another name is micturition. It basically means the person is going pee. It's an involuntary reflex, but you gain control over it. Control can be learned generally. So usually, obviously, babies are born, involuntary reflex, they urinate. Usually between 2 and 3 years of age, they learn how to be potty trained. And that usually stays with us, but we're going to find as we get older and the muscles weaken and the bladder muscle weakens, we're going to find that sometimes we lose that control again as the people get older. Adults generally produce around 1,500 milliliters a day of urine. And again, that's going to vary depending on how much a person drinks, but in general, it's around 1,500 milliliters a day. But we're also going to learn when we get to our nutrition unit, we're going to learn that people generally take in around 2,000 to 2,500 milliliters of fluid a day. So one of the reasons we don't expect urination to be the same, we don't expect what a person takes in volume fluid-wise and what they put out in urine to equal each other, because a person also loses fluid through perspiration, through exhaled air, and in their bowel movement as well. But 1,500 is a general rule. Usually around 100 to 300 milliliters of urine that gets in the bladder, that's going to start signaling those stretch receptors. Those nerve stimulation is going to happen to send that impulse up to the brain that you need to go to the bathroom. And so most people, like I mentioned, usually every 2 to 5 hours they need to go to the bathroom. Normal urine is kind of a straw-colored, light yellow, straw-colored. It has a faint ammonia smell to it. That's pretty typical. When a person's drinking lots of fluids and their urine becomes very diluted, it may look actually clear. When the person's dehydrated and their body's trying to retain as much fluid as it can, the urine can look like a really dark amber color, letting you know that the person's probably not taking in enough fluids. An involuntary loss of urine is called urinary incontinence. And urinary incontinence, unfortunately, is one of the main reasons a person ends up in the nursing home. So generally, many times when a person has a disability, their family tries to take care of them at home. But when that person starts becoming incontinent of bowel or of bladder, sometimes families just don't know how to deal with it physically or emotionally anymore, but it is the #1 reason people end up in a nursing home. Urinary retention can occur when a person cannot empty the urine from the bladder. So when we start looking at urinary tubes, we're going to talk about, sometimes the physician will put in a tube called a suprapubic catheter, and that's usually put in when a person has urinary retention. Some disease processes, for instance multiple sclerosis, many times the bladder doesn't empty anymore, voluntarily or involuntarily, and the bladder retains urine. So sometimes they end up having to have a urinary tube put in to drain the bladder. And we'll learn in a later class about urine indwelling catheters that go in through the urethra, and then there's suprapubic catheters that can go in surgically right above the pubis bone. And that generally happens when a person, the suprapubic is when a person has a disease process where they're going to need long-term urinary tubes due to urinary retention. There are a lot of things that can impact somebody's ability to go to the bathroom. So developmentally, we said kids are generally born without the ability to control their bladder. Obviously, it's an involuntary reflex. Around 2 or 3, they start learning control again. And then, unfortunately, as people get older, your muscle of your bladder is like the muscle of any other part of your body. If you don't use it, you lose it. And it's something that the muscles can start weakening. They can start atrophying when a person gets older. And people, as they get older, sometimes start losing that ability to control their urine. Food and fluid can make a big difference. Dehydration, when a person is not drinking enough fluids and their body is dehydrated, the kidneys try to reabsorb as much fluid as it possibly can, and it makes the urine very concentrated. It gives it a much stronger odor to it, and it will look much darker. When a person takes in large volumes of fluid, when they drink a lot, then their urine becomes diluted, and so it'll look almost clear or almost like a watery color. Caffeine and alcoholic beverages can increase urine production. They are diuretics, meaning they can make the person urinate more frequently. And salty foods, like a person eats a whole bag of potato chips, salty foods cause retention of water. It causes water reabsorption to help dilute some of that salt, and so that can, of course, make a person, actually retain more fluid. Psychological things that come into play with this, well, for one thing, if you're in a nursing home or you're in a hospital and you can't get out of bed to go to the bathroom because you're too weak, or you've just had surgery, or you have tubes in your body, you're going to have to rely on someone else to come and help you. And so emotionally, that can be really hard on a person psychologically, to deal with the fact that they can no longer control their own bladder, that they need help being able to go to the bathroom, or if they don't have control over it anymore, it's a huge emotional impact with them. Also, can you imagine being a patient in a hospital and you know you have a roommate right next to you, and that roommate has visitors and you're trying to use a bedpan, and it's really going to be hard to be able to urinate. So it is okay to ask family members of the patient next to you to step out while you're helping the other patient go to the bathroom if they're needing to use a bedpan. Activity and muscle tone play a big role in this. As I mentioned before, your bladder is a muscle. Your muscle can lose tone if you don't use them properly. So it is possible as a person gets older that their muscles start to weaken as they get older, and they can start losing control. And then pathological conditions, disease processes that happen, especially neurological disease processes, can really impact the control over urination. Medications can play a role. Some medications cause a person to go to the bathroom more. They cause diuresis, where the person will pee extra fluid out. Some medications can make people retain fluids. Some medications we can give a person, like when a person has a bladder infection, sometimes we give them medications to stop bladder spasms. It can turn the urine a bright orange or a different color. So medications can impact urination as well. When we're assisting with normal urination, we have to remember to provide fluids as directed. People need to stay hydrated, and a lot of times our elderly population, they will try not to drink as much because they don't want to have to go to the bathroom as much, because they know they need help, or they know they don't have good control over it, and it's not healthy for a person to stay dehydrated. So we really need to encourage fluids for our person, offer them help regularly. One of the things that you can do to help a person help keep normal bowel and bladder function is do what we call hourly rounding. Every hour we go by and we check on our patient. How are you doing? Do you need to go to the bathroom? Do you having any pain? Do you need to be repositioned? So we call it the 3 Ps, potty, pain, and position. And every hour, if we go by and ask our patients that, people say, oh, if I have to do hourly rounding, I'll never get all my work done. But what they have found is that when you go by every hour or so and you check on your patient and you reposition them if they want it, you offer them a chance to get something to drink, or or move in a different position, go to the bathroom if they need to. There's less incidence of incontinence, so you're not cleaning them as much. There's better patient satisfaction. They're not on their call lights as much, and they fall less. And so it's a really win-win all the way around. If we do get them up for normal, so we offer them help regularly, we also want to help them assume a normal position. So if the person can get out of bed into the bathroom, that is best. Or if they can't make it all the way to the bathroom, if they get out of bed into a potty chair, into a bedside commode, that's helpful. It's much easier for a person than trying to use a bedpan. Provide warmth and privacy, and if the person is really weak and you're helping them up to the bathroom, we need to stay right outside that door so we can keep an eye on them. We want to place the signal light and tissues in easy reach, so we want to make sure their call light and their tissues are, their toilet paper and stuff is right nearby where they're going to need it. And if we are leaving them, if they're not overly weak and we can trust them to be okay in the bathroom, we always, after every 5 minutes or so, you want to come back and check on them, make sure they're doing okay. After they've gone to the bathroom, hopefully they can wipe themselves. If not, we may need to wipe them, or we may even need to do perineal care if they were incontinent or got anything on them. And always encourage them to wash their hands when they're done. As far as using bedpans or urinals, this is a traditional style bedpan. This is going to go underneath the bottom. This is the part that slides up under the bottom. This is the part sticking out more to the feet. This is called a fracture pan. It's a little bit thinner. It slides under the bottom a little bit easier. And so if you have a patient that has had hip surgery or back issues, this kind of bedpan is sometimes easier for them to sit on. So this is the part that's going to go under the bottom, and the handle is out towards the feet. Now, some of your residents can actually, even these little old ladies, you wouldn't think they could lift their bottom up, but a lot of people can actually bridge. They can just push up with their feet and lift their bottom up so you can get the bedpan underneath them. If not, we would roll them to their side to put the bedpan underneath them. Men tend to use urinals for urinating, and some men will need to stand up to urinate. Some can do it in bed. They would hold on to the handle here, and you just take the lid off of it. You may need to help them put the penis inside the urinal, and most of the time they can hold it there while they're going to the bathroom. This is a urinal holder, so it's not just laying on their bedside table, where they put their food trays and their personal belonging items. We don't really want to put a urinal there or bedpans there. So this is a holder for the urinal, so it's always available, and we attach it to the bed rail for them, so the patient can reach it whenever they need their urinal. This is actually a urinal, a female urinal. So this is the type of a female urinal that can be used. So when we place a bedpan, like I said, we'll put the bed flat. A lot of times women can lift their bottom up, and you can slide the bedpan underneath them. If not, we roll them on their side, and we kind of have to push it down as they roll back over it so it doesn't just pop right out. And then after we get them on that bedpan, we want to sit them up. It's a much more natural position to go to the bathroom in a sitting up position. So we will sit them up to a comfortable height for them. Now, you do not want to leave someone on a bedpan for more than 5 minutes. They're miserably uncomfortable, and so you want to make sure that you give them their caulite, their tissues, something to clean their hands after they've wiped their bottom with it. A lot of times they actually can wipe themselves if they've just urinated. You may need to help them or do pericare afterwards if necessary. Bedside commodes. In the hospital setting, we use this type of bedside commode. This sits right next to the bed. The person can get up, they just lift the seat up, there's a pot, they sit down, it collects their urine, they can get right back in bed. You would just come and grab the pot, open up the seat, grab the pot out, empty it, and then put it back. So if you have a person who's allowed to get out of bed, but they really can't walk yet for some reason, or they're not supposed to be walking over to the bathroom, this is the type of device we could use. In the nursing home, we tend to use this type of device. It's a commode seat that goes over the toilet. So it raises it up a little bit, gives them handles to grab onto to help them get up and down, and it makes it a little bit higher so they don't have to sit quite so low. It's a little easier for them to get up and down. So in the nursing home, you'll generally see this type of device over the toilet. Now, when our patient or our resident urinates, we do want to make sure that we're actually observing that urine. And I know people are like, oh, I really don't want to have to look at other people's urine or bowel movement, but we really do need to look at it. We need to look at the color, because if we notice it's really, really dark, we know our patient may be dehydrated. We want to look at, is there particles in it? Is it red? Do we think maybe there's blood in it? Is there something that looks off to that urine? So we're going to notice the color. We want to look at the amount. Are they urinating an average amount of urine? We can actually be measuring it if we're concerned. In the hospitals, we tend to measure all urine that comes out of a patient. In a nursing home, not so much. Again, for many of them, this is their home, so we don't always measure all urine for all patients. We're going to look at odor. Is there an unusual odor to it? We said urine normally has a slight ammonia smell to it, but there's some other smell that we're noticing. For instance, foods. Foods can make a huge difference. Think of asparagus. I mean, it makes the urine change odors almost instantaneously. Particles, blood, mucus, if there's anything that looks unusual in the urine, before we just pour it out or dump it down the toilet and flush it, we want to make sure we let the nurse know. We're looking for blood. Blood in the urine is called hematuria, and we would look for that. Or pain. If the person's complaining of pain when they urinate, they're complaining of burning or discomfort, that is called dysuria. DYS in front of a word is difficult or painful. Uria is the word for urine. So painful urination, we would want to make sure we let the nurse know. Olguria means a scant amount of urine, and usually that's less than 500 milliliters in your 24-hour period of time. Remember, we said normally most people go around 1,500 milliliters in 24 hours. So if they only have 500 or less in 24 hours, that's usually considered olguria, a scant amount of urine. As far as urinary incontinence, it means loss of bladder control. So incontinence is lack of control. Urinary incontinence is lack of bladder control. They need kindness and empathy and understanding. This is psychologically very difficult for them. To be an adult and to go back to a stage where you were when, before you potty training. You know, I mean, it's really psychologically and emotionally a really detrimental thing for them. So we need to make sure we're showing them kindness and empathy and understanding. It is frequently linked to abuse. It's a common reason we said why people end up in the nursing home. It's one of the most common reasons a person ends up in the nursing home. And there are different types of incontinence. So there is what we call functional incontinence, where they can't wait to get to the bathroom on time. So they know they need to go to the bathroom, and they put their call light on, but they can't wait for you to answer the call light and get them there. So, and I always feel really bad, because many times you're busy with another patient. Maybe you're giving a bath to another patient, or you're in the shower room with another patient. Your person puts their call light on, and they're waiting and waiting and waiting for you, and they just can't wait long enough. Okay? Overflow. So when the bladder is full, little bits of it are just going to kind of dribble out. Stress incontinence, where it leaks when they exercise or when they're laughing. Reflex, where it leaks at predictable times. So let's say the person normally goes to the bathroom every couple hours, and so every couple hours they start leaking urine. So that's kind of a good key that you would know that they would need to go into the bathroom. Urge incontinence, where they're leaking during they have an overwhelming need to urinate. So they feel like they have to go to the bathroom, and then they can't hold it. I'm not even talking functional. They know they need to go to the bathroom. They can hold it for a little bit of time. If you get to them, they just can't hold it for an extended period of time. Urge incontinence, I feel like I have to go to the bathroom, and I go. I can't hold it at all. So when we're caring for the patient that is incontinent, answer our call lights promptly as we can. Good perineal care, otherwise that skin can break down. So people frequently ask me, if they're incontinent, why don't we just do a urinary tube for them? We'll be talking about urinary tubes in another class, and with urinary tubes, the chance of infection is so great. The chance of infection with a urinary tube is much, much higher than the chance of skin breakdown from being incontinent. Because if you do good perineal care, you do good skin care for this person, and you clean them up every time after they're incontinent, and you use barrier devices like A&D ointment, Balmex, you can keep that skin from breaking down. Change wet linen promptly. Okay, anything wet or soiled should be changed right away. We check the skin frequently for irritation and signs of breakdown. So when we're doing that perineal care, we need to look at the skin. Is it getting red or raw, or rashy, or anything like that that looks off to us? We want to make sure that if it is, that we make sure we let the nurse know. Hourly rounding, cannot stress this enough. It helps so much. It keeps the person much better control. If every hour we offer them the opportunity to go to the bathroom, to get repositioned, see if they have any pain, and let them know in about an hour we'll be back in to check on them again. Provide barrier cream if directed by the nurse. Now remember, we can do topical over-the-counter ointments. Topical means on the skin. So we can provide ointment on the skin if it is a over-the-counter ointment, not a prescription medication. So we're allowed to do topical ointments to intact skin if it's an over-the-counter ointment. Encourage Kegel exercises. So Kegel, however you want to say it. Again, muscles tend to atrophy if we don't use them, and that goes for the bladder muscle as well. So one of the best things you can do to learn how to do Kegel exercises is learning how to do it is when you go to the bathroom. So when you start your urine stream, you hold it, and you try to hold it for 5 to 10 seconds, and then you start your stream again, and then you stop it right away, and you hold it for 5 to 10 seconds, and then you start it again, and you keep doing that until you empty your bladder. Now, I can't say that Kegel exercises that while you're urinating is the best time to do them on a regular basis, but it is the best way to learn how to do them. Once you learn the motion of how to make your bladder and urethra muscles contract down and relax, and contract down and relax, you can do them at any time. You're welcome to do them while you're in class. It won't bother me a bit. We want to wear easy to remove clothing. So when patients have issues with incontinence, we want to make sure that their clothing is we can get it off easy if we need to. There's nothing worse when a person has a functional incontinence or urge incontinence, and they've got pants that buckle up and zip and suspenders. It makes it really difficult to get it all undone when we need to get them off in a hurry. So generally, when people are in nursing homes, we recommend to the families that they bring easy-to-remove clothing, pants that have elastic waists to them, so it's easy to slide them up and down. We do not refer to incontinence pads as diapers. They are briefs. Babies wear diapers. These are not babies we're taking care of in the nursing home. These are people that have had full lives. They've had families. They've had jobs, careers. They've done amazing things with their lives. And now their body's just kind of falling apart on them. They are not babies, and we cannot treat them as that. So we never refer to them as diapers. They are referred to as briefs. If we are doing intake and output, now, if we're doing intake and output where we're recording a person's intake that they take in fluids and the output that they're putting out, and a person is incontinent, we will usually just on the output sheet, we'll put incontinent times 1 or incontinent times 2. We'll just put how many times they were incontinent on our shift. So if you can't measure urine output because they were incontinent, that's generally how we do it. You can actually weigh the briefs. You can actually weigh an empty one and one that's full of fluid and actually take a weight on it. But generally, we just record how many times they were incontinent on our shift. When we do pericare for a female, and you'll be learning how to do this in the clinical setting, but you spread the labia, so the outer part, this part here of around the vaginal opening, this is your labia, and you spread the labia open, and you have a new clean washcloth, new clean water, and you're going to use one section of your washcloth to clean from top here to bottom on the inside of the labia, a new part of the washcloth with soap on it to clean from this side. Then you close the labia, another side of the washcloth to clean on the outside of the labia, and the last side of the washcloth to clean here. So 4 times. That's with soap on it. Now you're going to go back over it again without soap. So a whole new washcloth, top to bottom, inside of the labia, top to bottom, inside the labia on the other side, top to bottom from the outside of the labia, and top to bottom from the outside here. And then that washcloth's done. And then you're going to pat the front dry. Then you roll them over on their side, and when we clean the bottom, we cleaned to here, so this part here was clean, so we start from where we left cleaning off, and then we come up the bottom. So we're going to use one section of our washcloth up, another section up, this side, and we're talking with soap, one side over this side of the glutes, and one side over here, and then that washcloth gets tossed, and then we'll have another one to rinse the bottom, and then we'll pat that section dry. So at least 4 washcloths for perineal care. One to soap the front, one to rinse the front, and then you pat it dry. One to soap the bottom, one to rinse the bottom, and then you pat the bottom dry. Okay? If you do one stroke coming from this direction, from here up to here, you're going to take bacteria from the rectum and you're going to put it right here to that urethral opening, okay, where the urine comes out, which is a sterile system, and that bacteria, especially for a female, since we said that urethra is short, it's a straight shot into the bladder, and it can cause them to get an infection. So when we're wiping, when we're cleaning, we always go from top down. Perineal care for a male is also not quite as critical as a female, because again, we said the urethra, it comes through the penis and goes back into the bladder this way. If they're circumcised, so if the male has been circumcised where the foreskin is cut off, we start at the tip of the penis, that's the meatus, the opening of the urethra, and we're going to start at the tip, and we're going to go in a circular motion around the penis, and we can, you can actually just do one section of your washcloth and do around the tip of the penis. Then the next part of the washcloth, you go down the shaft of the penis, but away from the tip. The third part of the washcloth, you can do the scrotal area, and the fourth part, you can get the folds of the legs. When you're talking about an uncircumcised male, it becomes a little bit more critical. You have to pull the foreskin back to expose the head. You clean around the tip of the penis, you rinse around it, you dry it, then you put the foreskin back, and then you start cleaning the rest of the penis and the scrotal sac. So it's very important that if you retract that foreskin, that after you clean them, rinse them, and dry them, that you put it back where it's supposed to go. If you don't, you can actually, it can actually cause cut off the circulation to the penis, and they may end up needing to go for an emergency circumcision, which nobody's going to appreciate you for that. Incontinence products, we said they're briefs, they're not diapers, they come in all different sizes, and so we will be showing you how to, in the clinical setting, we will be showing you how to put these on correctly. If we are going to help with bladder training, part of it is going to depend on what type of problem they have. So bladder retraining, if the person has some issues with incontinence, we're going to see if we can help them get over it. So one of the things we would do, let's say they have functional incontinence, we can actually ask them to hold on to their urine a little bit longer, to postpone or delay their urination. And so they feel like they need to go to the bathroom. We'll help them into the bathroom, but we'll ask them to hold on to their urine a little bit longer to help tighten up those muscles, so hopefully it will build the muscles a little bit better and teach them to hold on to it a little bit longer, and we'll start trying to expand their times out. We may need to put them on a schedule, so we may need to put them on a schedule to get them to go at a regular time, especially if they have like a reflex incontinence issue. We may, if they're having issues with the bladder being full, we may do prompted voiding, so every 2.5 hours we remind them that they should go to the bathroom and to ask us for help, or to respond to the prompting, to take them into the bathroom and let them actually sit down and go. So there's different ways it can be done depending on what type of incontinence the person has. So generally what we do is we track their habits, like how often they're incontinent, how long they can hold it before they're incontinent, and then we start trying to build a plan around that to try to help them. And that is going to end our urinary elimination.